Good morning from Oxford. Salam alaikum. I have to start, of course, with an apology that I can't be with you there in person today. Unfortunately, I've got 2 weeks at the moment of work taking place at the London School of Economics. But I will be back in the kingdom a little later this month in Al-Azhar. I've been working there for a couple of months now. So I'm looking forward to being back. But this morning I want to talk really about a study which is, we hope, fingers crossed, about to be published. It's just being peer-reviewed right now. That was actually inspired by some comments that Jose made some time ago when he wondered aloud, I think, or spoke during a congress about cost effectiveness. And so I thought, well, oh, okay, this is something that's worth studying. So what I want to talk about just for the next 5 minutes is low dose rate brachytherapy as a primary treatment for localized and locally advanced prostate cancer, a systematic review of economic evaluations. So let me just take us forward there. There we go. Quick declaration right there, as you can see. So what's the background to this study? Well, our research question is, where does low dose rate brachytherapy sit with regards to both cost and cost effectiveness when compared to other treatment options for localized and locally advanced prostate cancer? So in other words, if this is the only thing you're looking at, then and you want to take the most value-based approach to delivering prostate cancer treatment to these patients, what treatment would you choose based upon the evidence? So we began by looking at studies published. We chose a cutoff date of 2008, and obviously we looked at everything published up until now. So over 15 years. We looked in Medline, we looked in Embase, and we also looked in a very specific registry that's maintained by Tufts Medical Center in the US, a cost effectiveness analysis registry. And we made sure that the study was registered, the study protocol was registered in Prospero. 2 reviewers, myself and another, independently screened the title and abstracts based on our agreed inclusion and exclusion criteria, which you can see in the table on the right-hand side of the slide. You can see that we were very clear about the population we were looking at, the intervention, low-dose rate brachytherapy, either as a monotherapy or as a local boost in combination with EBRT. Comparing with one or more primary treatments defined under the main guidelines, so watchful waiting, active surveillance, radical prostatectomy, or radiation therapy, and any kind of cost or any kind of economic outcome, cost effectiveness, cost utility, cost benefit, or they could be partial economic evaluations that just really had a conclusion regarding cost. We did not limit ourselves to any countries, we did not limit ourselves to any languages, but we did exclude adjuvant treatment or treatment for recurrent, metastatic, castration-resistant disease, and we also looked only at full papers. We excluded anything where we couldn't get full data. And we used the Drummond checklist once we got an agreed list of full texts to screen to critically appraise the quality of the included studies, which I'll speak about a little later. So here we go. Here's how that review went. We had 634 records initially, although 181 of those were duplicates. So once we got rid of those, we had 453 records. we decided that 36 of those were worth a closer look. And then that got us down to 14 eligible studies, of which there were 7 full economic evaluations, 3 cost utility and 4 cost effectiveness, and 7 cost comparisons. And of those, by far the majority, 11 of those, compared treatments for low and or favorable intermediate risk disease. 2 papers just looked at unfavorable intermediate and high risk disease, and 1 paper actually analyzed treatments for both groups. So actually you can say we've got 12 in one class and we've got 3 in another class. And therefore, this presentation inevitably is going to really be very focused on our findings with regards to low and favorable intermediate risk disease. So LDR-BT as a monotherapy. Suffice it to say, as I think is often the case with systematic reviews, there was enormous heterogeneity in terms of the perspectives, the time horizons that we saw, choices of discount rate where it was used, data sources, outcome measures, and sensitivity analyses used. So it would be very, very difficult indeed to pool, impossible to pool any of these findings. So let's go through the findings in order. And what I'm going to do is I'm going to quickly show you summaries of our findings with regards to each of the main comparators. And what you can see then for each of them on the right-hand side is a hierarchy showing exactly how low-dose rate brachytherapy has performed against this comparator. Let's start with active surveillance, because in a way, it's active surveillance that we were most interested in. Now, you'd have thought, wouldn't you, intuitively, that active surveillance will always be the lowest cost solution. But what we found is that's absolutely not the case. Now, let's just remember that the PROTECT trial found no significant differences between prostate cancer-specific mortality of active surveillance, radical prostatectomy, and radiation therapy. And indeed, active surveillance has been a preference for a very long time. Now, in our review, you can see there on the right-hand side that we found 5 studies where active surveillance was the comparator. Now, in 3 of those 5 studies, brachytherapy was less costly than active surveillance at a certain point in time, usually at least the 7-year mark. And in 2 studies, not only was brachytherapy less costly, it was also more cost effective. You can see those studies down there in the green area. So again, that was after a certain amount of time. Laviana, over in California, he and his colleagues found that after 7 years, brachytherapy becomes more cost-effective than active surveillance using every other year biopsy and MRI. Keegan, though, as long ago as 2012, found, Kirk Keegan, found a similar result. Now, arguably, the fact that at a certain point in time, which may anecdotally, this is not part of the study results, be actually getting shorter and shorter as active surveillance gets more expensive, challenge the orthodoxy that active surveillance is always the most economically advantageous treatment strategy for men in these risk tiers. Increasingly, as we get more sophisticated with the way that we surveil patients who have declined for the time being treatment, then it may well be that we find brachytherapy becoming more and more comparatively cost effective. Now, moving on then, what happens then when we compare low dose rate brachy with surgery? Now, we know that it's reasonable to consider radical prostatectomy as an alternative to active surveillance in suitable patients. Indeed, Professor Guinaud, has just described how maybe sometimes with younger patients we do too many radical prostatectomies. I think that's a very interesting question. Those patients obviously have to accept the inevitable trade-off between toxicity and preventing disease progression, which of course is the kind of the attractiveness of radical prostatectomy. Now, interestingly, 9 of the 12 studies we looked at for this class of patients did use at least one surgical modality as a comparator. Only 3 of the studies were full economic evaluations. And interestingly, in 6 of the 9 studies that you see down there in the green area, low dose rate brachytherapy was more cost effective than surgery. And those results come from studies that really do span more than a decade or so, including the most recent studies from Weng and Cato, both published last year, from Laviana and Kirk Keegan, and also an Italian study from Becchera Beccino in 2011 and Hayes in 2013. So it seems fairly consistent that we get that result. And it's interestingly, again, older studies that have tended to find that surgery was more cost effective than brachytherapy. So brachytherapy has clearly made some advances in this regard. It's being done very efficiently now. Now, with regards to other radiation therapies, beam therapy of various kinds, all 12 of the studies in the low and the favorable intermediate risk category compared low dose rate brachytherapy with at least one other radiation modality. And again, you see excellent results represented in the green area down in the hierarchy. Brachy was more cost effective than radiation therapy in 3/4, 75% of the studies, 9 out of 12. Now, interestingly, where you had some, should we say, just one marginal result in a study there by Hellu et al. In 2017, that was where brachytherapy was being compared with SBRT. But it really was the case that these two were kind of neck and neck, very easily matched. And brachy was very sensitive. So I should say the cost effectiveness was very sensitive to the probability of biochemical recurrence. So that was kind of a tie. But what is also interesting is when brachy's been compared to 3D CRT, in those cases, that particular newer beam therapy does win out. But on the whole here, you can see that brachytherapy is a consistently less costly and more cost-effective therapy than other radiation therapies. And then our final comparison in this class is against high dose rate brachytherapy. And here, the results are very, very clear, and they're what you would expect given the number of visits and the amount of time involved in these two treatments. All or 4 of the studies that compared low dose rate and high dose rate brachytherapy as monotherapy found low dose rate brachytherapy to be the most economically advantageous. So very, very clear result there that practitioners will not argue with. Now, then, in terms of cost effectiveness in unfavorable intermediate and high risk disease, there are really very few studies. We only identified 3 studies that actually looked or compared low dose rate brachytherapy with other treatment options. And there was not sufficient evidence to draw any conclusions regarding the comparative costs and cost effectiveness. There was just one study, a very recent one, Kowalchuk et al. In 2022, that showed that as a boost to external beam radiation therapy, brachy may well optimize both long-term qualities and costs, but I think we would need to see a lot more in terms of evidence to actually say anything conclusive about that group, that risk category. Now, systematic reviews always have limitations, and ours was no exception. There's huge amounts of variation in the perspectives taken. Sometimes it's a payer perspective, sometimes it's a provider perspective. Time horizons were quite variable. Now, I think it's fair to say that probably the median average time horizon used was about 10 years. But we did have some studies that took time horizons as low as 5 years. And I would argue that to really understand cost effectiveness for brachytherapy, that's just too short. And concluding that, for instance, active surveillance in younger patients is most cost effective when you're only looking at 5 years worth of data, I think is incorrect. It's methodologically incorrect. Choice of discount rate varied if it was even used. Data sources, I think we did see a real variation in the quality of the cost data used. Quite often in these kind of studies, the payment given to a hospital is conflated with the actual costs to the hospital of delivering brachytherapy, and they're not the same thing. The really good studies, the ones that I think work well and have great data, are the ones that use micro costing. So Laviana, for instance, used a technique called time-driven activity-based costing. It's a micro-costing technique to look at all of the costs that were involved in delivering brachytherapy and other therapies. Outcome measures can vary, sensitivity analyses. I don't think were used in enough studies or used extensively enough. And so for all those reasons, studies were often very different from a methodological perspective and therefore difficult to compare. Something else that's interesting, particularly in the older studies, is it's not always clear what type of brachytherapy they are actually evaluating because they just refer to brachytherapy. Now, sometimes you can actually, you don't find which type is in the title or in the abstract. You've got to actually read the content in detail to finally find out that what type they're using. Or in our case, we actually contacted a lot of the authors to get clarification directly. As you might imagine, this review was really dominated by American studies. And American study outcomes may not be transferable to other countries. We know how high costs can be in the US compared to Europe. I already mentioned that since the average age at the time of primary prostate cancer diagnosis is 66 years, follow-up durations of only 5 years when looking at costs, particularly when comparing brachy with active surveillance, are really not appropriate. And also, again, we've mentioned that some studies really did use very sparse or oversimplified cost data, which again might have led to a lot of inaccuracy and bias in those studies. So there we go. So in conclusion, the available health economic evidence suggests that low dose rate brachytherapy has significant cost advantages and therefore an important role to play in the delivery of value-based prostate cancer care. Low dose rate brachytherapy is consistently more cost effective than most other types of radiation therapy and more cost effective than surgery in many settings. Depending on the time horizon, it can be less costly and more cost effective than active surveillance. And also, as we've said, it's always more cost effective than high dose rate brachytherapy. Now, of course, we don't choose treatments entirely based on their cost effectiveness. But in a world where we are increasingly finding ourselves attracted to purchasing, for instance, very expensive Da Vinci robotic machines or expensive new linear accelerators, I think it is very important to bear in mind, particularly in countries with low and middle incomes, that there is a very cost-effective and low-cost treatment out there that has excellent outcomes, and it is low-dose rate brachytherapy. I hope that that's given you some food for thought, or at least just an interesting break from clinical studies this morning. And I'm very happy to take any questions that you might have. Many thanks indeed.